Shock is a clinical syndrome, and it is essentially a life-threatening response to alterations in circulation. What you wind up having in a state of shock is usually a low cardiac output state, and a lot of times you have alterations at the capillary level in the microcirculation, especially seen in times of septic shock. But when you do not have flow to the capillaries, tissues are not adequately perfused. Cells need oxygen in order to have aerobic metabolism. And so when they don't have oxygen, because of the shock, they will convert to anaerobic metabolism. So essentially, you have an imbalance between cellular oxygen supply, because you generally have a low cardiac output, and you have an imbalance and you have an increased demand, right? In a state of shock, your body usually has an increased demand for oxygen. So there really is this imbalance. And shock is not selective. It impacts all body systems. So if it's not treated or if it's allowed to progress, it's going to lead to organ failure and death. So whether the shock progresses or whether the organs fail is really influenced by the patient or the body's ability to compensate, and whether or not we have successful interventions. So one of the key nursing interventions or nursing assessments to do in shock is to recognize it early. So we know that the earlier we recognize shock and the earlier we intervene, the better we are at stopping progressive organ failure. So when you talk about shock, you really have to talk about two key components that are affected. One is really this idea of oxygen tissue, the imbalance between oxygen supply and demand, and the other is really what is happening at the in the microcirculation. Now, the microcirculation is where the capillaries are, and that is really where oxygenated blood is flowing in order to deliver oxygen to the tissues that need it and the cells that need it. So essentially, what you want to think about is that at the artery end or the arterial end, you have a lot of higher venous pressure, or excuse me, you have arterial pressure. So blood flows directly from the arteries down into the veins, and then the venules, and then into the capillaries. And this is really where the exchange occurs for the tissues. Now, one of the things that can happen in shock, or does happen in shock, is this concept of vasodilation, where your artery or where your veins are really just sort of what I call big floppy tubes. And you see this mostly in distributive shock, but essentially, when you have larger tubes, right, big floppy tubes, because you're so vasodilated, the resistance to flow is decreased. So there really is this direct correlation between, how dilated the vessels are and how much blood can flow through that. So when you have these sort of large amount of vasodilation, blood simply becomes sluggish and essentially pools in the capillary space. And if it's not going to move through back to be oxygenated, those tissues eventually are going to take the oxygen that they need, but there's not going to be any delivery of new oxygenated blood to them. The other component that's really important in shock is really this concept of mixed venous saturation. So if you think about the delivery of oxygen to the tissues, and I do love this picture because it really is a great visual on how the whole system works. If you think about oxygen being loaded in the lungs, so if you think about this is what's considered to be the oxygen train, and so think about oxygen that's being delivered. So oxygen is loaded in the lungs, and the hemoglobin are what the oxygen is being carried on. So here is your cars of the train, right? So hemoglobin, if you think of each hemoglobin as a car, a train car, and that train car is, each one is carrying oxygen. So it comes out of the lungs and it is delivered to the tissues by cardiac output, right? That is driver, that is the engine of the train, that is the driver of the oxygenated blood through the tissues. So the lungs, so the train comes out of the lungs, it is fully loaded with oxygen, cardiac output delivers it to the tissues. The tissues have a certain demand. In a healthy patient, they extract about 30% of the oxygen. They usually take what's dissolved in plasma first. So if you think about the oxygen or you think about the plasma, this is like the tracks of the train, right? The train has to drive on the tracks or in the vessels to get to the tissue that needs it. So inside the tracks, there is oxygen as well. So there's your PaO2, which is your partial pressure of oxygen. That is the oxygen that's dissolved in plasma. And your SaO2 is your O2 sat. That is really what you're checking to tell you how well hemoglobin is loaded with oxygen, right? That's the hemoglobin carrying oxygen. So in a healthy patient, your demand for oxygen is about 30%, which means that when the car or the train goes back to the loading station to be reloaded, the mixed venous sat, or what's left over, is about 70%. Now, in a state of shock, tissue demand is going to increase. So if the oxygen that's being delivered to the tissues, now if the tissues demand more than that, let's say they take 60%, so double the amount of oxygen because they have a much higher demand, when the train goes back to the loading station, the SVO2 is much lower and it's only 40%. So that would tell you, if you drew a mixed venous sat or if you were monitoring SVO2 or SCVO2, then that would tell you that if your mixed venous sat is very low, that the tissues are demanding more and they're using more. So one of the things that's important in shock is to maximize oxygen-rich blood to the tissues. Well, we do that in a variety of ways, and so these are really all the factors that get manipulated. Now, sort of going back to a state of shock, if your patient is very vasodilated, if in the state of shock you have a lot of vasodilation, I think of that as the tracks of the train breaking up. So again, if you're very vasodilated, your train isn't going to be able to drive oxygen anywhere because there's no vessel that's strong enough to push that train forward. So think about sort of vasodilation and the fact that your tracks are breaking up. Which is why a lot of times we use vasoconstrictors to improve cardiac output or improve blood pressure. So you want to load oxygen. Maybe we have to intubate the patient. Maybe we have to provide 100% oxygen for the patient. Maybe we need to, in order to increase delivery to the tissues, we need to add cars of the train. So we may be able to give the patient blood. Maybe we need a stronger engine. Maybe we need to improve contractility and add a positive inotrope for the patient. Maybe we need to give the patient more volume, right? That's another way to improve cardiac output so that there's actually more delivery to the tissue. So we can do all of that on the demand side, but if we don't, we can do all of that on the delivery side, but if we don't reduce the demand of the patient's oxygen requirement, we're not going to make much progress there. So part of managing shock is this balance between oxygen supply and demand. We have to improve supply, but we also have to reduce demand. Okay? So again, shock really begins when there's some cardiovascular system failure, and that's due to a variety of reasons. So it begins with an alteration in, circulatory problems, and a lot of times it sort of depends on what the state of the shock is or why the patient has shock. So, for example, there can be loss of blood volume, and that's usually the marker for having hypovolemic shock, right? So if you have a loss of blood volume, if you're extremely dehydrated, if you had maybe a large traumatic injury where you've lost a large amount of blood, you're going to have hypovolemic shock. You can also have an internal sequestration of blood where there's a blood has been moving into a body cavity that maybe it shouldn't be there. So for example, if you break your pelvis, you can lose a large amount of blood into your pelvis. So you have the signs of hypovolemic shock, but you're not losing blood outside the body. It's actually going into a compartment where there's a great volume can be lost in that compartment before there's any signs that there's really hypovolemic shock. You have an alteration in myocardial contractility, right? So the heart in, like for example, in cardiogenic shock, the heart simply fails to pump. Maybe you have severe heart failure, maybe you have cardiac tamponade, maybe there's something that causes, you've had significant heart surgery. So myocardial contractility is really the ability of the heart's ability for the heart to pump. There can be a blood flow problem or a vascular resistance problem. Maybe in blood flow, maybe there's some kind of in distributive shock, for example, in septic shock, you have massive vasodilation. When you have massive vasodilation in the microcirculation, you just have these big floppy tubes. So blood isn't going to go anywhere if there's nothing to push it through the tubes. So these are all components that that start the process of having symptoms of shock. Now, the body's going to attempt to compensate. So when one component fails, another attempts to compensate. However, in general, compensatory mechanisms usually fail or ultimately will fail if the underlying problem isn't corrected. And that is why recognizing signs of shock early is really, really important. So when you think about the stages of shock, there are 4 stages of shock. Pretty much every type of shock starts in this manner and progresses in this manner. It really just has to do with what is the underlying cause of the shock. So something has to initiate the shock, and this really stage 1 is the initiation phase. So this is really a state of hypoperfusion. And shock, again, occurs on a continuum, so what's most important is that if signs and symptoms are not recognized early, progression to the next stage is going to occur. So stage 1 begins with an initial state of hypoperfusion. And the interesting thing is there's not many obvious clinical signs. Usually, if the patient's being monitored hemodynamically, is being hemodynamically monitored, for example, if for some reason they had a central line, maybe you could draw a mixed venous sat, or you could monitor SVO2, or you can monitor cardiac output, but this is the earliest stage, and it is really reversible. So generally, there's inadequate delivery of oxygen. You have hypovolemia, the heart is failing to pump, you tend to have massive some vasodilation occurring, and there's an increased cellular metabolism that's occurring in the cellular level. So your patient's body, or the body, is using more oxygen. Now, what are you going to see in your patient? There's nothing obvious unless, again, you have invasive monitoring. But the good thing is that stage 1 is the earliest stage, and it is completely reversible should we actually recognize it and intervene early. If we don't, stage shock is going to occur again on this is the continuum. So again, sustained reduction in tissue perfusion is going to start the sort of compensatory process. Shock symptoms will start to become apparent during stage 2. Again, you have to think about what those signs and symptoms that you're seeing in your patient and why they're happening. So there is sustained reduction in tissue perfusion, and this is where the body begins to compensate. So the first thing that happens, if you think about the sympathetic nervous system, that is going to kick in. There's a neural response. Your baroreceptors and your chemoreceptors are very sensitive. Baroreceptors are very sensitive to changes in pressure because now there's low blood volume. Your chemoreceptors are very sensitive to chemical changes because now there may be less oxygenated blood. So the chemoreceptors at the base of the carotid sense that, and they relay messages, to the vasomotor center in the medulla, and that stimulates the autonomic nervous system, and that's going to release epinephrine and norepinephrine. So our friends that really are the key hormones that start or drive the sympathetic nervous system response. So you get these release of catecholamines, and that is going to increase heart rate, and it's going to increase contractility, and the purpose of that is to improve cardiac output. So again, if you think about a time when your patient becomes hypotensive or their blood pressure is lower, heart rate does increase simply to maintain cardiac output. There is an endocrine response as well, where ACTH and ADH are released. So ACTH is important because it's going to ACTH releases the mineralocorticoids and glucocorticoids that are important, from the posterior pituitary to increase blood sugar, and that is important because the patient may need to it may need sugar, right? As cells are burning a lot of energy, they may need some extra nutrient requirement. Then you also have the release of your mineralocorticoids that affect sodium and water. So antidiuretic hormone is important because you get the reabsorption of water. And again, the body is trying to conserve water because it's trying to maintain cardiac output. So what this does is basically turns on the renin-angiotensin-aldosterone system as well. And you get this sort of attempt to increase intravascular volume and pressure, which is really just increasing preload. You do end up with a chemical response where you start to have a VQ mismatch. This tends to lead, this low oxygen level starts to trigger the patient's ability for them to breathe a little bit faster. So you will see hyperventilation in your patient, and as they're breathing faster, they're going to blow off CO2, so a state of respiratory alkalosis really ensues. So the alkalotic state also results in vasoconstriction of cerebral vessels, and the patient may start to have some decreased cerebral perfusion. So when you think about the signs and symptoms in your patient, you really want to think about the fight or flight response, but you might see some restlessness as the brain is not getting enough oxygen. As you remember, restlessness and confusion are really the first signs of hypoxia. You're going to see tachycardia. You may see a decrease in urine output, again, because the body is trying to conserve water. You may see hyperglycemia if you check your patient's blood sugar. And you're going to see hear diminished bowel sounds simply because as the compensatory stage progresses, blood flow to non-vital organs gets turned off, and because the body tries to conserve blood to the vital organs, okay? So you will start to see the gut not receiving any, and you just don't need to use that vital organ. Now, still reversible stage if you recognize it early, and so that's again one of the benefits of understanding what's happening in your body at the time of shock. So, really, really important to recognize this early. Now, if we don't recognize it or we don't intervene, we are going to have a progressive stage. It's going to sort of have progressive tissue hyperperfusion. So if stage 2 is not really recognized and properly treated, you're going to have shock that's going to progress. So now you start to have a continued vasoconstriction. That's going to shunt blood to the vital organs, because really all it wants to do is perfuse the brain and the kidneys. Those are the most vital organs. And you wind up robbing the extremities of perfusion. So you may start to see sort of cool extremities from extremity ischemia. You're going to have the cellular hypoxia start to occur, and that is really going to produce lactic acidosis. So as the cells revert from aerobic metabolism to anaerobic metabolism, they are going to start to break down, and they will eventually produce lactate. And lactic acid is a sign that your cells are starving for oxygen. As this progresses, of course, tissue perfusion progresses and those cells do die off, you do have failure of the sodium-potassium pump, and that causes leaking out of the cells. So if you remember just the basic inflammatory response, once the cells die off, the sodium-potassium pump fails, the cell tends to break open, there tends to be a lot of capillary leaking, and those cells, it becomes this sort of messy process. You wind up with fluid shifts because there's capillary hydrostatic pressure increasing. Again, volume is just not really going anywhere. So fluid tends to leak out of the capillaries, and that further decreases vascular volume. And so this results in kind of a capillary sludging where you have, again, altered perfusion in that microcirculation. And you wind up with a decrease in coronary perfusion because there is a myocardial depressant factor is actually released, which actually decreases myocardial contractility. So this phase of shock responds poorly to fluid volume replacement. The patient generally will show some classic signs of and symptoms of shock. Every body system is sort of starting to fail at this point. So, again, if you draw this is one of the reasons why we draw a serum lactate, because if we can draw serum lactate early, we will recognize that this is an indicator of tissue hypoxia. You really can't rely on your oxygen saturation alone, because what happens is in a state of shock, patients will shift on that oxyhemoglobin dissociation curve, and the body, even though the tissues are demanding increased oxygen, the oxygen tends to be held onto the SAT, so you may have a higher SaO2 for any given PaO2. So one of the things we do early is a serum lactate. And what you see in your patient, now you're going to start to see in a progressive stage hypotension and narrow pulse pressure. You may see hyperglycemia again. You will see hear absent bowel sounds. There will be now a state of acidosis, because as the shock is progressing, you tend to see cold, clammy skin. Patients are much more lethargic. You may see cardiac dysrhythmias occur because of the decreased myocardial contractility. So every body system's starting to fail. If we don't recognize it now, certainly the patient, without intervention, the patient's not probably going to do well and will progress to a refractory stage of shock. So in a refractory stage of shock, this is now prolonged inadequate tissue perfusion. This tends to be unresponsive to therapy. So we now probably at this point, not only have we given the patient fluid, but the patient may be already intubated. We now are trying to improve blood pressure and cardiac output with usually medications or therapies. So now you tend to have sort of poor perfusion to organs, and you will start to see organ system failure. What will you see in your patient? Well, you may see refractory hypotension. You can see respiratory failure in ARDS. One of the concerns about, again, think about a body system, picture a body system in your mind, and think about what it would look like if that system is failing. So if in the respiratory system, you may end up with ARDS. In the hematologic system, DIC is a problem. You see DIC as a concern in septic shock. You have an AKI, your kidneys, as blood is being diverted away from body organs and there's low perfusion state. The kidneys don't like that, and so you can have renal failure. The liver, you have a tendency to have a state of shock liver where the liver is not getting adequate perfusion as well, and so you have an increase in your LFTs. Cerebral ischemia and poikilothermism is a very late sign, and that really is when your body can't thermoregulate anymore, so it tends to take on the temperature of the room. You see that very commonly in neurogenic shock. But essentially, this is multiple organ dysfunction syndrome. So this is a patient who's very sick, and obviously, without intervention, probably will not likely survive. So really, your treatment goals for the general management of shock are always going to be to treat the underlying cause. We have to reverse this altered circulatory component. So we have to make sure that we are maximizing cardiac output and maximizing volume so that the tissues are getting oxygen. We have to improve myocardial contractility. We need to reduce vascular resistance or manage vascular resistance. So sometimes that means a reduction or increase in afterload. We do need to reverse the tissue hypoxia, so we need to make sure that cardiac output is maximized. We do that with fluids. A lot of times crystalloids are really the first line of isotonic fluids are the first treatment or fluid of choice. We do that with fluids. We often do that with colloids such as Hespan and blood products. If your patient's hemoglobin and hematocrit is low, the patient may benefit from blood products as well. Pharmacotherapy really deals with managing preload, contractility, and afterload. So generally speaking, we usually need to increase preload. So we can do that by obviously crystalloids and fluids. We may need to add an inotrope, a positive inotrope such as dobutamine. That's really a very common inotrope that's used in shock to improve myocardial contractility, and we sometimes need to increase afterload, so we can do that with vasopressors. We do that sometimes with Levophed or phenylephrine, simply because we are trying to improve vascular tone in order to have much more tissue perfusion. So we can do all that. We have to not only maximize oxygen delivery by making sure that the patient is getting enough oxygen, we also have to minimize consumption. So again, if your patient's got septic shock and they're febrile, we need to make sure we're treating fever. We need to make sure we're treating pain. If they're on a ventilator, we need to make sure they're adequately sedated. Sometimes that requires paralytics as well. So again, this is really just a general overview. The biggest thing about shock is that we recognize that regardless of the cause, patients are going to progress through these 4 stages of shock, and if we don't intervene and treat it early, multiple organ dysfunction syndrome or multiple organ failure is going to occur, and that may cause the patient to not survive the initial shock insult.